try to show you some of the or the advantages of different available imaging modalities in evaluation of the craniofacial anomalies, so that you can make benefit of all what we have. And we'll divide these anomalies into 4 categories according to the anatomy and the embryology. Starting by anomalies in the nasal cavity, nasofrontal region, nasolacrimal apparatus, and finally with some of the craniofacial syndromes. The 2 main anomalies in the nasal cavity are the guanal atresia or stenosis and the piriform aperture stenosis. And of course, you know that the guanal atresia is one of the lesions that we encounter frequently in the clinical practice, especially for those who are working in the children's hospitals, like Apurish, for example. Then guanal atresia was previously diagnosed by a very old technique known as nasopharyngiogram, but nowadays the CT is of great help to assess this anomaly. And we have 2 main types of atresia: the osseous type, which is very common compared to the membranous type. And in the axial CT images, we can look to the posterior guana, and here you can see that there is a bony ridge which is obstructing the posterior nares bilaterally, and of course the accumulation of secretions proximal to the site of atresia. In this example, you see a membranous type of atresia on the right side with distension of the nasal cavity by secretions also. And here you can see bilateral membranous atresia. Of course, the posterior guana is usually narrowed, and then you can see some membrane here which is obstructing it posteriorly. Then this is the 2 examples for bilateral osseous guanal atresia and bilateral membranous atresia in another patient. And there are a lot of associations with the guanal atresia, many of the syndromes and anomalies in the craniofacial region. And I don't need to bother you by this. And the second type is the piriform aperture stenosis, where the distance between the nasal processes of the maxilla is abnormally narrow, and you got the medial bowing of these processes encroaching on the nasal aperture. And then normally you can see a good distance between both, and the processes are usually parallel to each other. And for diagnosis of this, we may need to have very thin sections by CT in order to image this in a good way. And there is no reported distance for the aperture, but it is stated in the literature that an aperture which is narrow, more than 11 millimeter, is considered of the stenotic type. And we can easily measure this distance by CT, and we can also have so many measurements in this particular area. Some of the commonly associated anomalies include facial hemangiomas, pituitary dysfunction, and central mega incisors, which is a common finding in about 75% of the cases. Then you may use the facility of multi-detector CT with 3D imaging reconstruction to nicely demonstrate the nasal aperture, and you can have the measurements, and you can also assess the thickness of the nasal processes of the maxilla as well. Then this is an example where you see severe stenosis of the nasal aperture and the medial bowing of the nasal processes of the maxilla. And in the coronal planes, you can also see the aperture, and you can evaluate some of the associations, including the narrowing of the bone inlet, the triangular shaped palate, and the abnormal dentation, as I have mentioned. Then the midline nasofrontal anomalies. We would like to have some words about nasal glioma, encaphalocele dermoid, and epidermoid cyst. And you know that there is a foramen here, or a duct, which usually regresses, and is totally closed. But if this canal or duct remains patent, there is a chance for the brain tissue and the meninges to herniate, so that there may be an encephalocele. But if the duct is regressed with residual remaining glial tissue, you may got what is known as nasal glioma, which may be an extranasal or intranasal or both. Then if there is incomplete involution of the dural diverticulum, you may get these the dermal sinus and dermoid cysts. Then MRI is very good in evaluation of this area, particularly whenever there is a good clinical suspicion that it contains neural elements, because MRI can show better the tissue of the brain, and they can show the characteristic signal similar to the intracranial part of the brain, enabling to accurately assess the contents of this lesion before surgical interference. And here you see this is T1 weighted image because the fluid is black, T2 weighted image, the fluid is bright, and you can see that there is a nasal encephalocele, and you can assess the extent of the brain tissue through the defect in the sagittal and in the coronal images as well. Then this is a nasal encephalocele, and you can see that the contents of the encephalocele is not CSF alone, but it contains some of the brain tissue. And this is very important. CT may not be able to see better the brain tissue. And this is MRI sagittal T1 weighted image and T2 weighted image. You can see a very big encephalocele in the nasofrontal area with a protrusion of the brain tissue, which is disorganized, of course, and some fluid in this encephalocele. By CT, you can appreciate the protrusion of this sac, and you may be able to identify that its content, the contents are of brain tissue. Then if you look to the MRI, then you see that the brain itself is herniating, and also you can see some CSF and the dural sac as well. And many times you can also assess this very common associated anomaly, which is the abnormalities in the corpus callosum. And here you see a very small part of the corpus callosum, the rest of the corpus is agenetic. And this is a CT scan showing a cystic lesion in the nasosmoidal area, and the coronal image shows defect in the skull base. And the CT scan cannot for sure detect the contents of this lesion, but here you can see that the lesion is herniating through the skull base into the nasal cavity. And in the T1 weighted image, it contains fluid which is black, and in the T2 weighted image, the fluid is bright. Then there is no brain tissue inside this meningeal, but there is a possibility that the optic tracts may be herniated in the wall of this meningeal sac. Then the nasal glioma is a rare congenital non-neoplastic lesion, and there is remnants of glial tissue which is in the midline, maybe at the root of the nose, and it may have also a continuation inside the nose. We have three types: the extranasal, the intranasal, and the mixed form. And if you look here and there, you can see that there is a swelling at the root of the nose, and this is CT, and you see the soft tissue mass, and also here. And if you look carefully in the sagittal image, you are able to identify that this lesion is not continuous with the intracranial contents, and there is no bony defect here. And this is one of the important findings in the sagittal images, whether obtained by CT or by MRI. And in this case, we can see a right nasal mass, and this mass is of bright signal because this is T2 weighted image, and it was proved by biopsy to represent an intranasal glioma. And this is an extranasal glioma. You see the mass, which is at the root of the nose, and you see the intact calvarium. There is no connection between the lesion and the brain tissue. But here in this particular example of the pathologically proved nasal glioma, you may feel that this glioma is continuous intracranially from these sagittal images. And hence the importance of the coronal images as well. And you can see the lesion inside the nose, and there is no connection between the lesion and the brain tissue. Then these are the differential diagnoses for the nasal glioma, which is frequently mistaken for dermoid cysts and so on. Then dermoid cyst or dermoid sinus will result from incomplete involution of the diverticulum, resulting in a sort of communication between the exterior and through the tract itself. Then this is a good example of a soft tissue mass at the root of the nose, and by MRI, and you can see the contents of the lesion. And also by CT and MRI, you can able to exclude the possibility of encephalocele by loss of the connection between bones, but sometimes you cannot differentiate between nasal glioma and dermoid unless you have fat in the dermoid cyst. And fat is in the MRI is the opposite of water. When water is black, fat is bright, and when water is bright, fat is black. And this is one of the ways to differentiate both. But here, by the CT, you may be able to see that this is fat inside this midline dermoid cyst, where this is a 3D reconstructed image. And here, an infected nasal septum, the dermoid cyst in the nasal septum, which has been complicated by an intracranial brain abscess in the frontal lobe, as seen by this contrast-enhanced MRI. And this is also a proved nasofrontal dermoid cyst, and because of the absence of fat, it will go into the differential diagnosis. But whenever you are able to see fat inside the lesion, and this is one of the helpful criteria. When this dermoid sinus is infected, you got enhancement. And this is the value of contrast-enhanced CT or MRI. By CT, this is a sagittal reconstructed image, and you can see the defect at the region of the lesion. And by MRI, you cannot see fat, you see only fluid. This is T1 and this is T2. After injection of contrast, if you got marginal enhancement, and this is the abscess or the inflammatory tissue, then you know that this is an inflamed lesion. Then we came to the nasolacrimal apparatus. We have the nasolacrimal duct stenosis and the dacrocele. This is, of course, the normal appearance of the nasolacrimal duct, as I have mentioned in the anatomy lecture. And frequently, the nasolacrimal duct may be obstructed here or in the proximal part, resulting in accumulation of fluid, and this fluid may be secondary infected, resulting in an abscess. And this is a classic appearance of a dacrocystocele, a cystic lesion filled with fluid by CT scan, corresponding to the anatomic site of the nasolacrimal duct in the axial and also in the coronal. This is the site of the nasolacrimal duct, and this is the dacrocystocele. If the cystocele is infected, then you inject contrast material, then you got marginal enhancement. Marginal enhancement of a lesion equals the presence of infection, and this is an abscess. Then being a dacrocystocele containing fluid, it will appear on MRI T2 of bright signal. And this is also coronal T2, and you can see the bright signal of the dacrocystocele. And this is also an example of dacrocystocele by CT, a cystic lesion corresponding to anatomic site of the nasolacrimal duct. This is the region of the nasolacrimal duct, and this is the cystocele. Then these lesions are, of course, very easily diagnosed by the clinical inspection and the examination of the patient, but I would like only to show you some of the ways that we have in our practice to help you in the diagnosis. And of course, the previous days we diagnosed this by the straight films or the panoramic views of the mandible. And this is an axial CT scan of bilateral cleft palate before and after bone grafting. And I would like to show you some of the facilities that we have considering the cone beam CT. And you can have these images, and you can have the axial, you can have the coronal, and you can have the sagittal, and the 3D reconstructed image. All these are provided on CD so that you can look at it in your clinic. And also you can stop any of these images to have the actual site of the lesion and assess your patient very thoroughly. Then finally we came to the craniofacial syndromes, and I would like to mention some words about these: the Crouzon syndrome, the Treacher-Collins syndrome, and the Upper syndrome. The Crouzon syndrome is one of the rare lesions resulting from premature craniosynostosis. It is associated with many skull and facial anomalies, and this is stated in the literature. Unlike other autosomal dominant craniostenosis, no digital abnormalities are present here, and this is one of the helpful criteria. These are the main features of Crouzon syndrome: craniostenosis, the flat occiput, the high prominent forehead, the exophthalmos and hypertelorism, coronal atresia or stenosis, mid-face maxillary hypoplasia, and mandibular brokency. These findings can very well presented by the 3D reconstructed images. And in severe cases, you got this abnormality, which is known as the clover leaf skull, and also the patient may develop hydrocephalus. And this is the clover leaf skull in the coronal CT scan and in the 3D reformatted images showing the typical appearance. Then associated with the Crouzon syndrome, one of the anomalies which is seen in about 50% of the cases, which is the stylohyoid ligament calcification, or the marked prominence of the styloid process, and also the Chiari malformation due to descent of the posterior fossa contents in the upper part of the cervical spinal canal, also cervical spinal anomalies. And this is Crouzon syndrome, and you see from these MR images that there is a good distance between both orbits. This is hypertelorism, this is T1, and this is T2. And one of the manifestations due to craniosynostosis, you can get what is known as silver pitten or copper pitten skull, where you see the indentations of the convolutional markings on the calvarial bone. And these are the main causes of what is known as copper pitten skull: increased intracranial tension, the presence of hydrocephalus or brain tumor, and the craniostenosis. You may get to the Treacher-Collins syndrome, and this is a very rare anomaly also, and it affects mainly the mandible and the zygomas as well as the zygomatic arches. Then one of the diagnostic features which is best appreciated on 3D CT scan is the bowing of the lower border of the mandible. And also there may be hypoplasia or absence of the zygomatic arch. And you can see, of course, different projections for the skull after 3D reconstruction. Here you can see the deficiency of the zygomatic arch bilaterally, and you see the hypoplasia of the mandible with the concavity of its lower border. Finally, the upper syndrome, and this is the incidence, and you have the patient have mental retardation, craniostenosis, brachycephaly, and of course some of the digital abnormalities like syndactyly, for example. And here you see the fusion and the hypoplasia of the phalanges. You see the hypoplasia of the face and mandible compared to the size of the skull. Thank you very much.